Our speaker for the Cambridge Health Alliance, on behalf of the Cambridge Health Alliance, is Dr. Shoma Stout. Shoma is trained as both an internist and a pediatrician. She now serves as the executive lead of the 100 Million Healthier Lives campaign, which is convened by the Institute for Healthcare Improvement, the objective of which is to support 100 million people globally to live healthier lives. So that's ambitious, but it reflects what I know about Shoma, and that she is passionate both locally and globally about improving healthcare and population health. That passion has been recognized by a number of organizations. She's actually going to be leaving us shortly because she's going to give a plenary speech at the mayor's office in Ohio. But we're very grateful to have her, at least for a few minutes, to talk to us about the Cambridge Health Alliance. Shoma?
Thank you so much, Jonathan. And I have to really thank Jonathan and Qualis, because as we were doing our transformation, Qualis was really a part of that journey. And so many of the people that I see here around the room have been people that we've learned from, collaborated with, we've visited one another along the transformation. So before I go into this, the one thing I would suggest as you're thinking about it is how you create a community of practice of people learning together about how you create transformation. Because whether it's within the organization or beyond the organization or at a whole country level, we've certainly found that that's been a critical factor to how we learn and grow and create complex, adaptive, whole system change together. And that's really what I'd like to talk with you about. For those of you who don't know Cambridge Health Alliance, it's what we now call an integrated care system, though what I would say is that really we had a bunch of silos that were more like people sharing apartments in an apartment building where you are friendly with one another at the mailbox or the holiday party, but really didn't think that your fates were interconnected. And over the last several years, since 2009, we've been on a journey to think about what it looks like to instead become housemates together in one place and to learn what it looks like to be interdependent. Now, Cambridge Health Alliance takes care of about 130,000 people, 2 hospitals, 12 community health centers, specialty side school-based health centers, but interestingly also is integrated with the public health system, actually supports the community coalitions and all of the communities that it serves, and links into the wide range of tertiary centers that are across the Boston landscape. We are one of the 6 training sites of Harvard Medical School. Half our patients speak a language other than English as their primary language. 80% of them, 70 to 80% of them are in public insurance. And we have 3,400 employees and 18 labor unions. And so we always say, if you can do it here, you can do it anywhere. And I really, to Andy's question to Donna at the beginning, this seems like Shangri-La. Is it even possible? I remember the stories of South Central Foundation talking about taking change one step at a time patiently and building things over 20 years. And that left us inspired at Cambridge Health Alliance to not say, oh my gosh, there's all this stuff, how do we ever begin to create change, but rather to very practically and systematically think about how we could flip our system and to change those things that mattered, whether it was payment that was holding us back or the design of care. And as we did that, over this 5-year period, we actually worked payer by payer to develop partnerships. We found a new partner and changed our payment system from 0 to 60% global payments and shared savings, and changed all the care underneath that in a way that allowed us to function as we described it, as a practice without walls. And today I'd like to share with you some of the lessons learned in that journey. When we started off, this is what our picture of our transformation looked like. We had this idea of community and population health. We were doing payment reform and delivery system reform with high-functioning primary care at its foundation and the interface between the specialty system, the hospital system, and the community. And we were doing a lot of things that related to understanding the partnerships we needed to create, the health IT, thinking about how we do things at scale, and the cultural transformation that needed to go with it. If I were to draw this picture today, I would make that community and population health part much bigger and much more central. In fact, we might flip what's in which bucket, because the reality is a person might spend 5,000 hours at home even if they have a chronic disease, managing that non-communicable disease at home, and only 4 15-minute visits at their primary care office, and thinking about how we optimize those 4 15-minute visits and how the whole team works to support people in the 5,000 hours, and how we think about what's happening to empower people in those 5,000 hours to manage their health and well-being is a huge part of where we see the opportunity is. We approach this as a human system transformation, and that meant that we adopted these principles of a patient-centered medical home not as a checklist of things to do. We actually wouldn't let people see the checklist for 2 years. Instead, we actually used human-centered design principles to invite people at every level, whether you were receptionists or medical assistants or doctors or administrators, to put themselves in the role of 6 people, 6 customer owners that might come through our doors. A 22-year-old single mom with a 2-week-old, a 67-year-old Spanish-speaking gentleman with diabetes and an amputation, and to build, first just with pipe cleaners and other exotic equipment like that, what they would want their health system to be like, and then to begin the test of change to actually develop the kind of health system that the people who come there might need. And what was interesting, of course, was by the time we got to the checklist, and we provided some supports around creating high-functioning teams and the base structures that were going to be needed. But by the time they got to applying for NCQA recognition, they all scored between 95 and 96 out of the total 100 points. It's just that they got there in a way that felt deeply intrinsically motivating and commonsensical to them, because it was about what it took to improve the outcomes for our patient population. And I would say that focus on getting real outcomes, getting real improvement in the lives of real people was a crucial factor in how we set up the transformation. Well, some of the things that we learned, often with the scraped elbows and bruised knees kind of knowledge of what happens when you actually do this kind of thing, we learned that every population is different. It doesn't mean that they're terminally unique, but the fastest way to actually develop the health system that they need is to walk in their footsteps, to walk alongside them as they're going on their journeys through the system, and to redesign it. And even better, to do that journey in their lives and to understand that in order to accomplish what they need to do that we've all asked them to do across the agencies that are supposed to support them, we're actually giving them 20 hours a week of work to do. And so when they miss an appointment, maybe that can be a clue about what we need to streamline from the flow of the patient's experience. Even better, we integrated our customers, our patients, into all of our redesign teams. We saw them as experts in the redesign process and learned what it looked like to do that. We learned the importance of aligning our financial, clinical, and policy transformation together. That if we're going to create whole system change, to create and sustain a high-functioning primary care system, you need to have the payments aligned to support a prevention agenda. And if you can't think about prevention and chronic disease management, if the payment doesn't support that, it's hard to keep sustaining that from a business perspective or sustainability perspective. And then above all, we saw it as a human system and cultural transformation. And that human system was both about who could provide care, so really rethinking the roles of our receptionists and medical assistants, not as receptionists and checker-inners, but actually as caregivers who were from the community, who were intentionally hired from the community, who had skills and capacity building that we built that was both about them re-envisioning their role in the lives of our people, in prioritizing the relationships that they had with the patient panel that we all belong to, and with creating pathways for professional development, whether it's regular ongoing training in things like motivational interviewing that helps people and patients engage in their health, or whether it's professional development opportunities through scholarships. By the end of this 5-year period, a critical mass of them had actually become the first people that have gone on from being medical assistants to becoming nurse practitioners, pharmacy aides, and other professions, becoming the first people in their families often to emerge sustainably out of poverty. And that may be one of the most important long-term implications of our transformation. The elimination of silos in a person's health continuum, both within and far beyond the delivery system. We realized as we began to map the journeys, we realized how discoordinated our rather wealthy system was. And as we created both IT used IT to link, for instance, primary care and specialists, got everyone to agree to create one common care plan that ruled them all in one place, that everyone edited, rather than having like 5 care plans per patient, which translates to gobbledygook when it comes down to, it's a very technical term, when it comes to what a person is actually experiencing. The more we did this, the more we realized how much duplication there was in everything we were doing. And the more that we were able to recognize that when a person wasn't thriving, it was an opportunity to stop, to create a stop the line moment, to understand what was happening, to revisit that care plan, starting with what's really going on in that person's life, and inviting them to share what their goals are and what we could do to help them. We found out that patients had amazing expertise about what would work in their lives. And we began to really trust that expertise. And as we did that, we reduced hospitalizations for chronic disease by between 1/3 and 2/3, depending on the chronic disease. And I could go on and on about it, but one of the things that we learned to do is to really think from a person and population up about the design of the system. Who are the top 5% at risk at this moment? Who are the rising risk? It turns out that in a Medicaid population, which is the public sort of insurance for people who are under 65 and are poor or disabled, you actually don't have people who are at risk in the same way as when they're older in the Medicare population. In the Medicare population, you're old, you have heart failure, you just get older and you get more heart failure. Kind of. Does that make sense? So you just get sicker. You're stably high risk. In a Medicaid population, are you homeless or not? Are you experiencing violence or not? Do you have an addiction that's active or not? You have dynamic risk. And so we built our IT systems to give us immediate signals of risk so that we could immediately outreach to people. And by doing that, we were able to improve hospitalizations by 40% and emergency room visits by 50%. And the most important thing we realized we needed to, we thought proactively about people with chronic diseases in that second bucket here. And thought about how the entire system worked, both in the 5,000 hours and when they were in front of us, to meet all of their needs all of the time, whether that was for prevention or chronic disease. We made the EMR customizable so that the clinician could say, this is how this person is different, and it would pre-populate the recommended needs all in one place. And we changed all of the workflows of the entire team so that people reliably and systematically were empowered to move things for people. Before I ever go into a room as a primary care doctor, usually the person has begun to be cared for from the moment they've come in or before to the waiting room. The receptionist begins their care. Before I go in, their medications have been reconciled. They've been screened for things that they may need screening for. Their labs are drawn for chronic disease management. The patient has set their own goals, has identified what they're ready to work on, and usually they're telling me what they plan to do and asking me my advice about whether their plan is right. That's a very different kind of visit for someone, and that's for a safety net population of low-income people who have been able, with a 50% language gap that now has outcomes at above the national 90th percentile for quality. And that relationship that everyone discussed, rather than have these teams be separate and segmented, we have the primary care team is the relationship team. And they bring in other people into your life as you need it and serve as the primary relationship base for you with the whole team. And we can go into who's on what team, there are details, and we have a toolkit if you look for the Cambridge Health Alliance toolkit. But we bring in additional team members. But at the base, we really see that the medical assistant, the receptionist, the nurse, the PA, and the NP, or the resident who's integrated into the team are all working together. We've integrated our education and academic training processes so that people are functioning in teams and have continuity with one another so that it's not a resident per rotation, it's one group of people that they're working with. And then as you have higher and higher risk, people like nurse practitioners, pharmacists, and others come in to help support you. And if you're complex, as in your life is really bad right then, you have people who are really mapping out your life and working with you to do that. You've already covered many of these in prior talks today, so I'm not going to go into this. But the entire system is built around the working of this team whether it's co-location or the way the day flows or how people organize their time to think about what happens in those 5,000 hours that someone spends at home is all scheduled into the day, so it becomes the way the flow works. And there's accountability for who is doing what on the team. These are not my patients anymore. The medical assistants and receptionists who are on union salaries will call people on the weekends. They'll find people when they run into them at the grocery store and get them in for the things they need because they're their patients. And they call them my patients. And I think that's a huge part of the shift. As we continue to do this, we realized we needed to innovate more and more because we quickly realized that, for instance, mental health is primary care. When 1 in 4 people have a mental health issue, you cannot refer them to a mental health clinician who's going to see them for a series of visits. We redesigned our entire mental health model to actually think about what people who are social supports can do, who are functioning as life coaches, what people who are non-licensed and licensed could do to support the team and meet the patient right where they are, to do universal screening and support the primary care team to be able to manage mental health and to be able to escalate, but in an asynchronous way, leveraging technology, so that 4 psychiatrists can actually manage the entire improvement of health and well-being for this population, using some of the same principles that I think the Project ECHO team does, but also doing asynchronous encounters and charts. And I'd be happy to talk more about this during that breakout. But by really breaking down who's at what population level and designing the system based on population level, we made huge improvements. And finally, we made our IT systems work for us to help us know who's likely to be at risk before they became at risk, before something fell through the cracks. And that ability to think proactively and to be able to reflect proactively and to know and manage things like mental health just as we would any other chronic disease was crucial. I'm just going to share with you, as we went, we realized more and more people that needed to be integrated. First, we integrated the payer-based care management system, and then patients began drawing us, like those people on our redesign teams, maps of their lives that look like this. That's like, here we are, we're changing things, and we're so excited. And in fact, we're even integrating this blue bubble of everybody who's involved in the specialty care and primary care of my child with a special health care need. But these are all the people that are needed to help my child to thrive. And most of us don't, it's invisible to most of us. The person who's really managing all of this is the family. And that family has usually had to quit, somebody has to quit their job to manage all of that. This helped us begin to think about how do we go outside the walls of our healthcare system and integrate with the key sectors, whether it's the education sector, the housing sector, the social service sector, in our pursuit of integration. And as we formed our ACO, we were just as intentional in forming relationships with these groups as we were with others. I've already cited to you some of the improvements, but I'll just share with you, we were able to achieve a 36% reduction in hospitalizations for all-cause hospitalizations for our entire population of people with diabetes. We were proud of that. Only problem is this red line. Those are the number of people who got diabetes during the same time. They doubled. Now, a third of that was because of Medicaid expansion. We got more patients. But the majority of that was because people went from having obesity to an insulin resistance to prediabetes and diabetes. This is an epidemic throughout the developing and the developed world. And I think we need to think differently about where we begin to create change. And as we began to integrate with the restaurants, with our employers, with our schools, we began to see that there are new possibilities. We were able to improve obesity levels between kindergarten and 8th grade by 20% compared with matched controls and change their behavior over time. And as we began to think about the fact that our assets weren't just the ones that were restrained within our healthcare system, but our healthcare system could be part of a community system for health and well-being, we began to achieve the really breakthrough outcomes. As we began to see that kids spend every day at school and every day at home, our ability to change their asthma outcomes by empowering the school nurse with the tools she needed and the ability to get the refill she needed, and to get the Department of Public Health, who wanted to visit the patients to do the asthma education in the home and notice when there's mold or other environmental factors that need to be ameliorated. In a year, we began to see plummeting rates of hospitalizations, and now we're at about a 90% reduction in hospitalizations for kids with asthma, with a highly functioning, coordinating primary care system that's proactively noticing when kids are running out of control or meds and managing the outcomes better. Kids shouldn't be in the hospital. They should be playing in the playground. And that's really our view is that if we can build a system that creates health, then we can think differently, especially if we're thinking of integration in a completely different way. Thank you so much.